Thank you, sir. And actually, these open fractures in children, you all know that it is easier to treat because the healing is faster and infection rates are lower. However, you also know that if you have these injuries and then even though they have blood loss, bone loss, if you can keep it nicely stretched, if the periosteum is in adequate length, in fact, you can see that good spontaneous regeneration also takes place. So essentially, pediatric injuries are relatively easier to treat. But there is little controversy. There is actually no controversy grade 2 or 3 fractures. Whereas type 1 fracture, there is some controversy do exist. And this is the article that Professor Vikash shared with me saying that this is the status now, what is the So when you take this meta-analysis, they found that it was mainly about saying that the grade 3, the complications were higher, as you all understand that. But what he also said was grade 1, 2 fractures were commonly managed non-operatively and associated with lower infection rate. Operative intervention was more frequent in grade 3A injuries. That means all three grade 3 injuries were operated, whereas the other ones were non-operated. But however, few of the reports also did come in which said that if you do surgery, there are more complications in grade 1 injuries. Because they said that when you debride it and then when you are making the wound bigger by extending the incision, you are making type 1 into type 2 or type 3 injuries, and that devascularizes the bone ends and strips the more periosteum, and then it can result in more complication. That is how they went on to argue on this non-operative management. So there are many articles that came in, not only that one article, but there are many which came in favor of saying that just non-operative would be okay in small wounds in pediatric age group. However, you also must understand that suppose if you have one pulmonary embolism in a fracture, you want to give Clexane to the entire population. And those concepts also must ring in your mind because you see like 5 devastating cases of gas gangrene followed non-operative management in open forearm fractures. Non-operative management in open fractures is potentially dangerous. Type 1 open fractures should receive, so all those are written up. So there is a bias between so whatever you think, whether it is right or wrong, you have to actually clinically apply it in those situations. In our hospital, like we did have pediatric open injuries 916, of which grade 1 open injuries were 188. 17% of them were grade 1 open injuries. If you look at it, among them, these open injuries, we treated nearly around 11.1, that is around 11% of the patients as non-operative method. Like we just we didn't take them to theater, we just cleaned up and then put a dressing and then manage it with either the plaster or whatever that was required in those scenarios. So that means around 10% were only treated with like that. Whereas remaining, they went into theater for some procedure. Either it could be just like a cleaning, washing, or just scooping of the wound and then application of the plaster or Ender's nail or something like that, or the tense nail, whatever the situation that required. So you can see that this one area where it was just a clean and dress and casting. So this is a very small wound. Of course, you all agree that it's more like a closed injury. And this another wound, you can see that it's a small wound. See, like generally when there is a fracture in adult, you will see that the bone protruding out, and then you will see that. Whereas because it has got a thick periosteum in kids, generally that type doesn't happen too often. So that is why there will be a wound, but still it will be all the bone will be contained very well within the soft tissues. So you can go ahead to do this. So just like wash and pinning, and then you can also see that it is wherever a procedure required for a bone. If it was an open fracture, you always do some procedure for the soft tissue as well. So that's what has happened in all these situations. Whereas here you can see a small wound. Again, we just scoop it out and then put an external fixator. So what we do is in grade 1 open fractures can be treated like a closed injuries. Antibiotics are given like a closed injuries. And then when treated by conservative method, like just 5 days of oral antibiotics we give. And dressing with betadine and plaster application for conservatively treated patients. No wound washing is done in casualty. Just Like if somebody needed a procedure for the fracture, then they are always taken to the theater. So, but to get an answer to it, so there is an ongoing trial that is going on. Probably by next year it is going to be out, where it is a prospective trial that they are doing it for a pediatric type 1 open fractures. Probably when that happens, we will get an answer to that. But as of now, in our setup, we do 10% of them without any of them taken to the theater. But actually, they will all be like a very minor wounds. All those which required a procedure for a fracture situation, they all had something like a scooping or a mild debridement. Like that, it would have been done to these patients. So overall, you must take it into account that depending upon your setup, whatever that is required for the patient, if you feel it requires a DB, you do it. Otherwise, still it is valid to go on to do a non-operative method of treatment. Thank you very much.